Good afternoon, and after a long weekend, we have some report and data updates. Lots of things going on in that regard. You've already heard from the Premier as well as the Minister of Education about announcements regarding stage one of phase two. And so we'll have some aspects there, as well as the Minister of Education noted comments about school closure until the end of this current school year, and some comments about daycare and other aspects of that. So there's quite a bit going on there, and we know we're going to have some more announcements coming up this week on other things. So we'll have to stay tuned to that as we deal with the stage one of phase two, with some things opening up, but those are all still under the parameters of the 6 foot distancing, facial coverings if you cannot maintain that distancing, and all the other things of etiquette, and refraining from still the gatherings of over five, except in circumstances like funerals, etc., as before. So we haven't eased off that one at this time. So it's stage one with cautionary reasons, and part of that is with our data and information, which we're going to talk to you now about. So I'm going to hand things over to Dr. Yaffe to talk about how our numbers went over the weekend as we start this next 2 week period, which really started yesterday, but this is our next 2 week period, which is our first 2 weeks of stage one of phase two. At least 2 to 3 weeks in this time. As we said, it is a phasing, and we're going to have to watch that and monitor during this next time. So over to Dr. Yaffe and today's numbers.
Thank you very much. Good afternoon. I want to first begin by acknowledging that today is Personal Support Worker Day, or PSW Day. Thank you to all the PSWs across Ontario for your hard work, your dedication, and caring for those who need support every day, and now during COVID-19. Over the weekend, we saw the daily increase of cases of COVID-19 remain under 400. On Saturday, we saw an increase of 391 cases. On Sunday, 340 cases. And yesterday, an increase of 304. Today, we have a total of 23,384 confirmed cases reported in Ontario. And this is an increase of 427 cases, or 1.9% over yesterday's report. 57% are female, 42% 60 years of age and older, and 63% are people who live in the Greater Toronto Area. 17% of our cases are in healthcare workers, or 4,043. This is a cumulative number and does not represent those currently sick or positive. We continue to see Ontarians recovering from COVID-19, with 77%, or 17,898 of our cases considered resolved. Currently, we have 987 people in hospital. 167 of them are in ICU, and of those, 123 are on a ventilator. And tragically, we do continue to see deaths related to COVID-19. To date, 1,919 deaths have been reported, representing an increase of 15 deaths from our previous report. With respect to long-term care home data, until now, the data provided in the daily EPI report was based on IFIS, or Integrated Public Health Information System, outbreak data. These data were reported by long-term care homes to public health units in aggregate form. It included the number of residents and staff with lab-confirmed and non-lab-confirmed infections, and the number of people, residents and staff, who had died. Starting today, the number of cases reported will be based on the number of lab-confirmed COVID-related cases in residents and staff from long-term care homes. This means that the information captured will include residents and staff with infection from COVID-19 based on confirmed lab tests. These data will provide Ontarians with a comparable measure for COVID-19 cases for people in long-term care homes as the measure we are using for the rest of the population. So when we look at these numbers for today, there are 220 active outbreaks in long-term care homes. 4,235 confirmed cases in residents. This is a cumulative number. 1,456 confirmed cases in staff. 1,115 deaths for residents, and 3 deaths reported in IFAS for healthcare workers. While the way the data is being reported is an improvement, we do still see differences between the IFAS data and the Ministry of Long-Term Care data. These daily data may still not immediately match the numbers posted by the local health units due to lags in reporting time. We will continue to look for ways to improve our public reporting on cases of COVID-19. With respect to retirement homes, according to the information from the Ministry of Seniors and Accessibility, which is provided by the Retirement Homes Regulatory Authority, 64 retirement homes are in outbreak and 181 deaths have been reported. With respect to laboratory testing, 559,794 tests have been completed. In the last day, 5,813 tests were completed, and we have 2,294 tests that are currently under investigation. With that, I will turn it back to Dr. Williams.
Thank you. And so you can see there is that we're in a period of time here where we're changing from one method of testing priorities to another one. I should say our priority testing has not changed from those who get priority results back, and that's the same as before, which I won't repeat at the moment. So that has and will not be changing. But as far as doing wider testing on aspects, as you know, we have completed the long-term care survey, which was no small feat. We're doing well over 170,000 in a 2-week period, some done before, of course, in that line. And we achieved results of over 97% of the residents and over 90% of the staff, which is quite remarkable and work well done by all, especially by the local public health units in the province of Ontario. And those results are still being worked on and still coming in as the lab tests are getting completed over that time period there. So we'll wait to see and get that coming in from that. We then had decided that we would open up to wider testing at our assessment centers on the weekend, and we did send memos and information up to say that not only people with considerable symptoms, but with any symptoms compatible with COVID-19 would be tested. And there was some concerns that even though it was on a weekend, we might get a large number of people coming forward and getting tested. But as you can see by the numbers here, by the time we hit Monday, coming over, where it dropped from 9 down to 5. So that large inflow of people coming to get tested did not occur. Now, it may be, as they have seen in the past, that's a weekend effect. So let's see what happens as we go into the week. At the same time, this gives us a moment to look at our testing strategy and as a command table to decide what areas of priority beyond the general public that we want to look at. And then as we're trying to analyze here to look at these numbers, especially we've gone over 400 again, why was that? Where did it occur? Because it doesn't occur uniformly across the province. It's in different areas, and it doesn't occur even uniformly within some of the larger centers. So we need to be much more adept at getting granular on that data and analyzing it, and to see what we can do that we may have not only institutional outbreaks that are occurring, we may have what you might call community outbreaks, and we want to look at those and how to handle that. So we're in this transition phase and looking to go to the next one on that. We are continuing improving all our metrics as we have now entered stage 1 of phase 2. We're going to be watching that data closely as we go forward and looking at other methods of how we would want to contain some aspects to keep our R0 or transmission rate down and even get it down lower if we can. We want to see that over the next 3 to 4 weeks, at least 2 to 3 minimal, 4 weeks maybe, as we see how this progresses and how effective we are at doing more things in a safe, contained way, with ongoing vigilance in keeping the 6-foot distancing, facial covering if you can, and all the messages we've been saying before, hand hygiene, and all these new companies and retailers doing what they need to do to operate within those constraints. And so we want to see how effective we are at that. And the public, of course, continuing to participate in that way, although we see this more and more people being, I would say, sometimes more casual with that, which is unfortunate. We want you to maintain vigilance because we don't have to see another return back in a large wave again. And I'm not sure this 427's at, but it shows us that we still are quite active, and we still have to be assertive and consistent in our approach in dealing with this issue over the next 2 to 3 weeks of this period now. So with that, I'm going to open up for questions from media.
Okay, we'll go to the phone lines.
Question is from Kenyon Wallace at the Toronto Star.
Hi, doctors. Thank you for taking my call. Dr. Williams, last week when we spoke about the spread between long-term care homes and community cases, you had mentioned that there were approximately somewhere between 45 and 50% of cases in the community that we believed at the time. If you look at the new numbers posted today, it would indicate that about 25% of cases are in long-term care homes, and the remaining 76% or 75% approximately would be either in the community or in other institutional settings. So I'm just wondering what changed between then and now to see such an increase in the number of community cases?
So, well, thank you for the question. I think if you're looking at the same chart, which was attached to the public document, the one for there is you'll see that if you look at the total between those two, where you do that percentage, it represents about 1/3 or less of the cases of the 427. So those are the ones that are entered thus far. If you go back a few days before, when more of the complete data is entered, you'll get a truer representation of what the ratio between the two are. Now, I'm going to put a caveat on that in a second here. So it takes a while for the Yaffe system to enter those. So it starts off early with the community cases entered, and then the ones related to long-term care take a few days lapse later on. So if you go back to like the 13th and 14th, you see you're back into that 45, 50% community, 50, 55% long-term care. The caveat is, of course, and that's what we want to see, is that since we have finished the survey, in fairness, we should see what you're predicting. So that number, as they enter the more complete data, should stray much more towards a higher percent community and less in the long-term care, because we have completed the survey. It's just a matter of lagging tests coming through. So in a way, you may be correct, but I think it's premature to conclude that at this stage. Let's see what happens in about 3 or 4 days when they have all the data entered.
Follow up?
Okay, I'm just reading what's on your website, and that is there's approximately 23,000 total cases, and of those, about, say, 5,200 are either cases of residents having the virus in long-term care or staff. And if you do the math there, it works out to about 24.3% of the 23,000 overall cases. So these are just numbers I'm getting off the Ontario website. But I guess if I'm to interpret what you're saying correctly, what you're saying is that this could be a result of a time lag here, and they may not be 100% accurate. Is that correct?
Not inaccurate, it's just not timely. So it's as the data gets in. If you look at the overall 23,384, the breakdown is 58.5% is outbreak or contact, and 41.5% is community. But that's based on accumulation over a long period of time. I'm saying as they enter more and more data, and I think we have to look at now this next phase, since we finished the big survey of long-term care homes, I think we'll see that percentage even as the data gets entered. So it's not inaccurate, it's just not up to date. As it gets entered, I think, as you're asserting, and I think it would be true, we should see much more of a shift towards higher percentage in community, less in long-term care, because we're doing less testing in long-term care at this time.
Next question.
From Cynthia Mulligan at City News.
Hi there, doctor. So I'll follow up with what Kenyon is asking then. In your estimation, is it still roughly 45, 50% of cases are from community spread?
What I said was that up until this past weekend and 3 or 4 days ago, that is true. But remember, we completed the survey of long-term care homes on Friday. Samples still came in on Saturday and Sunday. Very few, I would guess, on Sunday, and there should be even less on Monday. So I think as we go forward, of the 9,000, 5,000 tests, more of those would be community, less long-term care. But all that data hasn't been totally entered yet. I think what we'll see in the next few days is there'll be a shift over to a lot more community percent, less long-term care.
Follow up?
Okay, thank you. My other question is, with your changing how the long-term data is now being assessed, are you changing the baseline on the very day that the phase one of the economy opening is happening?
So if I'm understanding, let's see, you're saying how we're doing the data, extracting it from our data system and putting it directly into long-term care numbers, which we did with some data rectification. How does that affect going into stage one? Is that what I'm trying to follow your logic there.
So I'm trying to interpret the numbers with the differences in data reporting now, and I'm just wondering, going forward, have you created a new baseline? Like, are we starting from zero and comparing past numbers?
I'll try. I mean, we aren't starting from zero. What we're doing is we're just clarifying the data. It's more accurate now because we're using data from IFAS that's individual level data rather than the outbreak data. The outbreak, there's like two different databases. There's a outbreak database, which includes cases that are lab confirmed and other cases that were just epidemiologically linked or didn't have any lab data. And then there's a separate database just for individual cases. So since we're testing now routinely, first of all, we've tested every long-term care, but even in an outbreak situation, we're testing everybody with symptoms and asymptomatic contacts. We have better data to reflect what's really going on in long-term care. So we're using individual level data. So we're not going back to the beginning. We're using better data to show what's happened and what will happen going forward.
Next question.
From Allison Jones at Canadian Press. Please go ahead.
Hi, doctors. I'm hoping you can explain the public health reasoning behind seeing schools not reopen in June, but potentially having daycares reopen in June if that's when we get to stage 2.
So in that aspect there, as we've been meeting with the Ministry of Education with their staff, and they were needing to know if our community numbers were low enough that we were less concerned about transmission. And as you can see by the numbers today, I was not comforted enough to say, no, we are still concerned about that. So on that basis, the Ministry of Education and the minister made a decision to keep the schools closed for the rest of the school year. At the same time, we have already opened up a number of the child care centers for essential workers and expand on that over the last while. We have gone about testing a number of the staff, or all the ones that are currently open, and we've pretty well completed that. In there, we did have the one outbreak, and that was dealt with, and it was a unique situation. So at this time, it seems in the because most of the centers are at schools and that are located in those physical facilities, that the Minister of Education asked about opening up more, and it was under the context of, one, they would have to be opened up in with the current guidelines that are applicable to the essential service child care centers. That means all the rules around numbers and spacing and children with proper protection, that kind of stuff with the staff, and monitoring that situation. So it's opening because there's a need to say, if you're increasing that over time, if you're going to start to open that up, it has to be done safely, monitored correctly with a local medical officer of health and team, along with partners in the Ministry of Education. And as a result, then people, if they are returning back into the work situation, some require those child care services to assist them. But we want to make sure that they're going to be opened in a time when it is safe, and we can ensure the safety, the health of the children attending, as well as the staff as well. So that is a work in progress at this time.
Follow up?
So is the difference then between daycare opening and school opening that you've just had these essentially test cases that you can look at with the daycares for essential workers?
The centers, the child care centers that the minister was talking, one is under the auspices of the Ministry of Education in a transfer payment agreement. So that's the one that the minister was talking about. And those ones that would be opening up would be a continuation of the same type of requirements that were for the essential workers, that all those would have to adhere to and to put in place prior to opening and meet all those standards if and when they open in the next while. And I didn't get the actual dates of all the different timelines of when that would be, but that's up to the Ministry of Education and in consultation with their transfer payment agencies and the ones who run the various daycare centers in that context.
Next question.
From Siobhan Morris at News Talk 1010. Please go ahead.
Hi, Dr. Williams. I know that you said that there were some more announcements going to come this week, and there have been some suggestion of this last week. Can people expect that you will be announcing that they'll be allowed to expand their social circle, that more people will be allowed to congregate in one place, or maybe some bubbling of families be permitted?
Well, we're continually looking at that. We've been talking to our scientists and various modelers and experts. We're looking at what our counterparts are doing across the rest of the country, and various provinces are doing different things. So we have been making some recommendations up and through into our counterpart at the command table and on up to the Minister of Health as well. And so we're continuing that process. So we hope to have something to announce in regard to that perhaps later this week. But we're still in the process of reviewing and coming up with those recommendations in that regard, and continue looking at the science and evidence as well as our epidemiology and our data, as we see the issue is still of large numbers in some areas of the province and how to handle that.
Follow-up?
Needing to wait to see what happens with the numbers from over the weekend about whether we're looking at more community spread. Would that be, a determinant about whether you decide to expand people's social circles or not?
Well, I think that's all we said all along with the public health measures table. It would be driven by the data and how we're progressing along the line there. A number of the metrics did look good. I'm hoping the 427 is a blip due to data shifts and changes, and we'd see it come down again further. At the same time, what kind of changes you'd make would be in the context of where you're at, and what does that, if you carried out something, it doesn't increase the risk to the general public writ large, but would deal with some other aspects that are important also in this time as people are asking questions in that regard. So there is a balance in there, and we hope to have some clarity on that perhaps by the end of the week.
Next question.
Will be from Jessica Smith at Queen's Park Briefing. Please go ahead.
Thanks so much. I have another question for you about the new reporting of long-term care data. You said the old way included some cases that were not lab confirmed, and the new data includes only lab confirmed cases. Yet the numbers jumped up; they didn't go down. Why?
Yeah, that's a question that I asked myself this morning to understand the data. Basically, you're right. The original data was the aggregate data, and it included cases that didn't necessarily have lab confirmation. They were epidemiologically linked. However, we know that the outbreak data is not up to date. It's not complete. And in fact, health units don't even have to input all the data for an outbreak until 2 weeks after the outbreak is considered resolved. That is the pattern that we use right now, the requirement. So we know that data was incomplete, and we know that this data now, because we are routinely testing in an outbreak, everybody who's symptomatic or asymptomatic contacts is getting tested. And of course, we've just gone through this massive surveillance testing of all the long-term care facilities. We have much more complete data now in the database that's for individual people who have had a lab test. So yes, the number went up by about 1,000, and that probably reflects better on the actual number of cases in long-term care facilities.
Follow-up?
Yeah, thank you. Earlier in the briefing, Dr. Williams, you spoke about getting more granular on the data. Getting more granular on the data. What did you mean by that, and what additional kind of data do you hope to collect to understand things better?
I think it's important in the case contact management as public health staff now have stepped back from spending quite a bit of time doing the long-term care survey to focus on doing their case contact management. That means looking at various ideas around where you might be thinking there is some clustering or gathering of cases. You may find places of local spread. Perhaps some institution was being less than vigilant in maintaining spacing and distancing. Perhaps there was some events that went on that didn't adhere to the 6 foot distancing and that, and so there was transmission in those locations. That takes a lot more energy and time, but is very critical because you may have a cluster of cases that, while it looks like your overall numbers are up, you're dealing with very much a focal entity that could be easily, not easily, but we're properly contained and mapped, walled off so it doesn't spread to the wider community. So that type of granularity, getting down to locations, institutions, geospatial mapping, all that kind of stuff is very important as we try to contain and draw it down, because there are still cases and transmission occurring, but we'd rather know where they occurred, why they occurred, and how we can do steps to limit those type of events. In a way, we talk about like the brush fires, putting out those local flare-ups. While the whole place isn't affected writ large, but you may have some localities in some different health units in different areas. So that kind of granularity.
To the last reporter.
Next question is from Emily Pelletier, Le Droit.
Hi, doctors. Can you explain why there were this many new cases announced today, considering that we had our lowest testing in a while? Like, if the province had done 20,000 tests, couldn't there have been hundreds more cases?
So, I mean, that's the question I asked, and I was looking at there, and what we found is that some of the places that were reporting testing, as you noticed in the past, our positivity rate kept dropping down. We were down below 4% for a while, down to 3.1%. And when you're doing a large survey of 170,000 people over a period of time, of where some places where the presence of the organism is very low, in fact hardly found, you're mixing in there large numbers of tests of a positivity rate of less than 5% in there, maybe less than 0.2%, and that tends to overcloud the issue. When you draw back from that and you get some sampling from various areas, even within certain parts of certain communities and areas, then you get some higher positive percentages there, because people still ill are still coming forward. We're not necessarily getting yet on the weekend all the healthy people that are sort of not, they're not healthy. They have some symptoms, they've had some symptoms, and we want them to come forward and get testing. Probably on the weekend they said, because the long weekend I got other things I want to do, we can't force them to come forward, but they could come forward, and we've got to see what happens in the days ahead, because there's been a general sense we should be doing wider testing of the population, and our centers are open for that, but we can't force people to come. They have to be willing and want to come. If they're not sick and have no signs or symptoms at all, they may say, why would I go and get tested? So that's part of our idea, and to see, are we going to get an upsweep, or are we going to stay at a certain number? That means I think our positivity rate can change depending on which assessment center, if they happen to have a cluster going on in their respective jurisdiction at that time. That affects on a smaller number the overall percentage and cases. So I wouldn't say if you did all of a sudden another 20,000 tests on a low prevalence group, say a general population of asymptomatic people, you could drop down the percentage positivity rate quite well, but you would see that that would be a bit artifactual, because you just did it by doing a large group that you knew was going to be low prevalence anyway. So you got to make sure you separate survey versus community testing.
Okay, follow up, and this is the last question.
I remember you told me a couple of weeks ago that your team would look into the difference between the genders, as women are more infected in Ontario than men. Have you figured out why there's such a difference, and it's still happening today?
Well, I think, and these are just hypotheses, really. Really, I think it's a combination of factors. Probably that the healthcare workers that are affected, that are mostly women. We talked about it's PSW Day today. Nurses and so on, and also that the preponderance of cases, 42% are 60 years of age and older. So as you get into the older age groups, there are more women than men. So I think it's just a combination of factors.
Okay, thanks everyone.